welcome to the second day. Let's get this started. We have only 1 hour and a half, and the room is already booked for the next session right after this one, so we don't want to delay, and the people who will be late will just catch us where we are, right? And so this is the third session of the Digital Health Hub. Yesterday, we had 2 interesting sessions. One was about the state of digital health in Africa, and the second one was about how do we break silos and make sure that government builds communication platforms and the right partnership within governments to allow digital health between ministries of ICT and ministries of health, so that to allow digital health to collaborate. And this session, the third one, will kind of discuss what is the technologies, what are the success stories, and what are the challenges of the specific technologies that are acting in digital health, and how do we go about it. And later in the afternoon, or midday, and then the afternoon, we will have more sessions discussing about public-private partnerships, and the right next one after this one will talk about non-communicable diseases and universal health coverage, and what are the solutions that are addressing those. This will be a lively conversation, and it's a great pleasure for me to welcome a very interesting panel and very distinguished panelists that we will have here today, and I encourage you to engage them as much as you can. And to welcome the first panelist, Shivon Byamukama, the Deputy CEO of Babil Rwanda. Please welcome. And a hand of applause as they take the stage, if you don't mind. Our second panelist, it's Walter Kerr, Chief of Staff for Zenith Technologies. Our third panelist, Anuradha Gupta, Deputy Chief Executive Officer for Gavi, the Vaccine Alliance. Hiroshi Kato, Vice President of Japan International Cooperation Agency. Vijayakumar Bhagavatula, Director of CMU Africa. And Francis Akan-Biemo, Executive Secretary and Head of Ondo State Primary Healthcare Management Board, Ondo State, Nigeria. So let's get started and try to deep dive in the conversation this morning on digital health and the technologies that are being used to kind of address the challenges that we currently have. And I will start on my immediate left. It's unfortunate that she gets to be the first to start, but she will set the tone for the conversation here today. I would like to hear more about what you do, and what do you think is so special about Babil Rwanda, and how do you think it's beneficial in low resource settings? Yeah. And maybe one thing, we will be sharing the microphones. They are right on the middle seat, so look on your left or right. Thank you.
Thank you very much. Thank you for the introduction and for inviting me to this very important and timely panel. Our global mission is to put an accessible and affordable healthcare in the hands of everybody on earth. It's by no means not very simple mission, but is it achievable? Yes, it's something that we can achieve. And what are we trying to solve here in the world? There's a global challenge of access to healthcare. In the developed world, somebody will take about a week. In the UK, for example, when they ask to talk to a GP, it will take about a week to see a GP. In Rwanda, you see the GP the same day, but you better take a day off, because you're going to wait in line, you're going to wait for long queues to be able to do that. So it's not just a developing country problem, it's a global problem. And what happens is, because you're thinking, okay, I have a headache, or I'm not feeling well, I don't want to wait in line for all day, and so you will take long to go and seek the medical attention that you need. And what starts as a $10 problem will eventually be a $10,000 solution or a $1,000 solution. And that not only squeezes you financially, it squeezes your insurer, the government, and all these challenges that take place. And why do we have this problem? It's essentially because doctors are a scarce resource globally. It takes you 7 years to get a medical degree. They're just generally a scarce resource. In Rwanda, the ratio of patient to doctor is about 1 in 20,000, but that's doctors. So we have, the government has, health centers, PPPs with health posts, community health workers to try to bridge that gap. But it's still a challenge. I think the Minister of ICT yesterday from Benin was saying that their ratio is 12 to 10,000 healthcare professionals, not doctors, but all healthcare professionals. Interestingly, I was reading research in Sweden as well, and their ratio is 1 to 2,000, and they're trying to use digital technology to reduce that number to 1 in 1,500. But what if we say that this is solvable using a technology that you already have? Everybody here in this room definitely has a mobile phone. So you can have healthcare using the mobile phone that you already have. And what that does is it allows you to have access when you need it, right? We have about 16 doctors and 16 nurses, but we use majority of who are on a part-time basis because they work in the hospitals that they operate in. One doctor can do about 42 consultations a day. And that with the 16 doctors and nurses, we can do about 2,000 consultations in one single day. So what we're doing is that we're getting the limited resources that is available and stretching it a little bit further to reach more people. The other thing that we are doing is using artificial intelligence to stretch that even further. We have 2 artificial intelligence mechanisms. One is called CheckBase, one is called PGM. The CheckBase is a triage tool that is being tested currently in Rwanda. We know in our call center, we're not using it publicly at the moment. And one of the quick wins is that we see that it has improved, triage already. But the PGM, which is also still being tested in our head office in London, is an actual diagnostic tool. So it will tell you this is what you are suffering from. It's a diagnostic tool. In the long run, we hope to put, after the testing phase is finished and so on, we hope to put this in the hands of health professionals in community, in health centers, right? In the longer term, though, because at the moment it's working in London and people are using it on their smartphones. But because people in Rwanda, only 10% have smartphones, we have a USSD platform to do that. And what we're doing is, we've developed this technology so that a call center person, a non-medical professional, just like is working in London, can be able to do that. And what are we developing? I think that when you're developing technology, it has to be easy, it has to be convenient, it has to be meaningful and usable. We have developed a USSD platform. It's very easy to use. You just put a USSD platform, put your NID number, registered. As a result, we have 2 million people registered on our platform. It's easy to use and relevant. We have 180,000 people who have done appointments with us. We are current in about 8 districts, which is 106 health centers, 102 pharmacies, and so on. And these are, people are now accessing easy and healthcare. And maybe quickly, I'll just say that it allows you to keep a lot of data and so on.
Truly innovative. Thank you so much for that. And maybe moving to Zenis, I would like to hear what's your story and unlike Bubble, which has been having the spotlight here, we didn't hear much about you. So if you could tell us what have you been working on, and especially in resource setting environments, and what are the key milestones that you think you've achieved in relation to the theme of this discussion?
Sure. Well, thank you also for having me. Just as a little bit of background, Zenesis Technologies is a Silicon Valley-based firm, and the big trick that we do, the big problem that we solve is rapid integration of myriad different data systems and data sources. So within a Ministry of Health, for example, you might have a health management information systems, logistics management information system, dozens and dozens of spreadsheets, different surveys that are conducted, et cetera. And what we do is enable end users, policymakers inside the Ministry of Health to combine any number of different data elements from any number of these different systems, and then look at that data in a triangulated way at any level of aggregation, over any time series. And then on top of that, we have some additional machine learning tools that you can also use to do things like forecasting future disease burden or supply chain stockout, et cetera. I think the first thing that I would want to emphasize about in terms of where can we have quick wins in low resource settings really gets to this point of data triangulation and instilling a culture of data triangulation inside ministries of health. Whether you're working with a company like ours or you're doing it on your own, ministries of health can do data triangulation today. And too often what we see is and ministries will say this themselves, is you have one team, an immunization team, for example, only looking at their immunization data in terms of making policy decisions, not considering supply chain data, for example. Or you have a malaria team only looking at the malaria health management information system data and not considering commodities data or survey data, for example, to identify where they need to direct interventions. Building a culture of data triangulation can yield such incredible benefits to a Ministry of Health, or any ministry for that matter, whether you be an ICT ministry, Ministry of Education, et cetera. And so there's a few examples in one geography, for example, by working with a government to combine immunization data with supply chain data, with immunization coverage data. That particular government was able to identify $30 million in savings in terms of how they were administering their national immunization program. In a second example, working in a different geography, by combining routine health management information system data with supply chain data, this particular government was able to identify which facilities were prescribing the wrong medications for routine cases of malaria. And then in a third example, by combining malnutrition data from the routine health and management information system, malnutrition data from an infectious disease surveillance system, and financial data about where the government was allocating resources to combat or to address malnutrition issues. This particular government identified about 70 districts that had among the highest malnutrition disease burden in the country, but were receiving among the lowest levels of funding. And with end-of-year money, we're able to direct about $125 million in a highly targeted, data-driven way. Now, you don't need sophisticated technologies to do this. It helps, and a software platform like ours enables you to, at will, choose whatever indicators you want from any systems to automate this kind of triangulation. But the example I just gave, where this particular government identified that prescriptions were being prescribed for routine cases of malaria, they were prescribing the wrong types of drugs for that. That whole triangulation was done using Excel. The data is there already inside of ministries of health, and often it's just a matter of getting the data together. It's not a trivial task to do triangulation across systems. It's complicated, and that's part of the problem that we help to solve. But you don't need to go out and wait for the perfect system. You don't need to build the perfect system. You don't need to get all data systems integrated into one system to do this work. The work can be done now, and by realizing major health savings in terms of the way that you're allocating resources, you can ultimately improve program delivery, identify service gaps, and improve public health outcomes. And then the last thing I want to mention is that none of this work can be, at least the way, when we're working with outside partners like ours or outside companies, none of this can be done in a vacuum. Technology is not a panacea. It won't solve all problems. And so while we provide governments with an incredible tool, unless there's capacity building that goes along with it, it will often be used to ill effect or not used enough. And so it's very important, at least we take the approach that when we do an implementation, we work side by side so that not only do we get the technical piece right, we get the usability piece right so that we're using data for decision making. And not just doing technology for technology's sake. We're actually using technology to address real policy priorities that ultimately serve to improve public health outcomes. So with that, thanks very much, and looking forward to the discussion.
Yeah, thank you so much. At a later point, we'll probably get back on how you contextualize it for the needs of the places where you are working in. If you don't mind me, I will probably skip the two panelists in the center and get to hear from the director of CMU Africa, Prof. Kumar, on, you are training African students in Africa. I'm curious, what's your approach on training them, and especially in relation to developing solutions on the continent, how do you build an institution that can also act as an incubator, and where people also build partnerships to create innovations that do matter and that address real challenges?
Thank you very much. So as Walter was mentioning, capacity building is a very important part of meeting the challenge of using digital technologies for improving health. We know that there are lots of different technologies being developed now, electronic data records that will improve the collection of data, more accurate data and more timely data. We also have sensors, wearable sensors that are being developed that you can wear on your wrist or on your chest to monitor health signals. There is data analysis techniques. Once you collect the data, to use AI, artificial intelligence, and machine learning techniques to extract information from these things. And then there is visualization and display data. I think previous panelists talked about the importance of visualization, especially when there is scarcity of medical professionals, qualified medical professionals. They're not there in rural areas. So if you have connectivity, there is an opportunity to collect signals or images or videos, and assuming that you have sufficient bandwidth, to be able to transmit it to a location where a qualified person can take a look at it. And Shivam was basically talking about using technology, low-cost technology, to increase, to scale up to 2,000 patients they're able to handle per day. So there are all these technologies being developed. There is also the need for essentially qualified people to take this data and develop solutions that actually speak to the context of Africa. The solution is not for somebody to parachute into Africa and try to solve the problems. What we are doing at Carnegie Mellon is to train African students in all these technologies, data science, cybersecurity, software engineering. One of the things we don't talk much about is power systems. You can have all kinds of things, but if you don't have power, a lot of these things are not going to be working. So how do you develop microgrids for the local areas? So these are all important things that these people, we need to train students on, so that not only will they develop low-cost solutions, but they also sit in leadership roles where they can evaluate the solutions offered by others, and then they can make decisions. So our mission at Carnegie Mellon has always, it's not my phrase, my predecessor basically says, our mission is to train African engineers in Africa for African applications. And that's why we are here in Kigali teaching, and we have graduated close to 100 students, and they are in very important roles, and 10% have gone on to are doing PhDs now, but the 85% are engaged in developing the next generation of technologies, not just for health applications, but in general. So that's our mission here. Thank you very much.
Thank you. Still on that end of the panel, I would like to hear from the Executive Secretary of Primary Healthcare Management in Ondo State. And could you tell us briefly what has been the success stories in Ondo State of integrating technologies in responding to primary healthcare challenges?
Thank you very much. The background information is that the Ondo State Primary Healthcare Development Board is the largest agency in the State Ministry of Health. The population of Ondo State is about 4 million, and we have just about 4,000 health workers. The health indices are not good in terms of maternal mortality, infant mortality, under 5 mortality, and we have this challenge of inadequate human resources and poor data management, because the PHC board have 583 health centers scattered across the entire state, with plenty of, more than half of those facilities in hard-to-reach areas. Our challenges are, how do we improve the health of our people? How do we improve data quality? We know a good health workforce is essential if we want to improve the health indices. And we partner with ISRAC Global Technology, with Imansat, UK Space Agency, and Qualcomm to use electronic data management to improve data quality, to provide video training for health workers where they are, because it's so difficult to bring people from a very large span of land to a place to train. What we did is to deploy this video technology, video training technology, to train our health workers on ways to resuscitate children delivered with birth asphyxia, how to provide quality antenatal care, how to conduct safe delivery, and how to do basic laboratory investigation. So that video technology has been deployed to almost all our health facilities. Besides that, there are areas, like I told you, we have poor infrastructure. There are areas where there are no network at all. And ISRA provided some tablets for, and we as a state bought into it and bought over 400 tablets. And these tablets need network to function. The international partnership project, which is being funded by Imansat and UK Space Agency, provide network where there are no traditional network system in those facilities. As of today, 3 local governments are already benefiting from it. We have 15 in Odibo local government, we have 12 in Idore local government, and we have 10 in Akoko South East local government. Now, those areas don't have network. Besides using the satellite technology to collect data, they also use it to improve the quality of care they give, using WhatsApp technology or messaging. If there are issues, the health workers send messages to their peers, and even senior health workers who will guide them using the WhatsApp message. Sometimes SMS are used. So those are the innovations that are coming out from using this technology to improve quality of healthcare. And also, early warning outbreak system for epidemics is another thing we have using technology to work on. Recently, there's an outbreak of Lassa fever, and we have these cases in remote areas. As soon as we noticed that, what we did was to immediately deploy people to those sites using those technology to be able to track patients, contact tracing, input information on the tablet, so that analysis will let us know where these cases are coming out. Quick response in terms of intervention becomes easier. Usually, it takes days to do that, but with this satellite technology, within hours, we already get results from the analysis using that clinic-packed tablets. This has been the intervention we've been doing in Ondo State. And it's also helping us, like I said, bridging this human resources gap, because our health workers are now were informed on how to do basic medical interventions.
Thank you so much. That's a very interesting use case on a primary healthcare level. Coming back to the Deputy CEO of Gavi, well, I know Gavi champions innovation in approaching how we solve access to vaccine, but also I would like you to talk about why is it important for Gavi to champion not only research and development, but also beyond research and development, and what has been your success stories so far, and what is your vision on that?
So thank you, Israel, and good morning to all of you. Gavi, as you rightly said, is often hailed as the 21st century development model predicated on innovation. In 2000, which was really the year of Gavi's inception, we embarked on a series of innovations. We brought public and private sectors together. That was a time when it was rather unprecedented. We started to work with low-income countries, 73 in number, now supporting a birth cohort of 80 million children every year, which is 60% of the global birth cohort. And you can appreciate that ahead of the SDGs, actually 15 years ahead of the SDGs, we were so focused on equity, and we really wanted to drive equity, riding on a series of innovations. I think what Gavi brings is a very comprehensive lens to innovation. And what we did was we looked hungrily for opportunities along the value chain for innovation. For example, around financial instruments and financing mechanisms. Like, that was the time when Gavi leveraged capital markets to issue vaccine bonds and raise $5 billion, really an innovation. And that helped us front load our investments in countries and fast forward impact. We also did market shaping, extremely innovatively, like advanced market commitments and things like that. So really, it was a series of innovations that helped us achieve the impact, the amazing impact that we have been able to accomplish in resource-constrained settings. For example, by the end of this year, we would have supported these 73 countries in additionally immunizing about 1 billion children, actually, about 700 to be specific, 700 million children, averting about 10 million future deaths. So this is the kind of impact that Gavi has been able to create through innovation. However, we also recognize that the innovation ecosystem is evolving very rapidly. And digitization is really opening up a lot of new, exciting opportunities for us. And we really want to stay ahead of the curve. And therefore, we put in place an innovation accelerator that we call Infuse. And Infuse is our innovation for uptake, scale, and equity in immunization. And as I said, immunization achievements are impressive. We are now reaching about 64 million children every year with the basic vaccines. But we realize that we still have 15 million children who stay deprived of the most basic vaccines. And we are so focused on them and leveraging these new technologies in order to get to that last child and close the gap in immunization. So through Infuse, we actually have been able to identify a lot of new pace setters. Genesis is one of them, where we are looking at new possibilities of data triangulation. A lot of times, a lot of you I know are public health experts, and I have seen people complain about paucity of data. Frankly, I don't agree. I think there is a lot of data. We are swimming or drowning in data. But what we don't do well is, as Walter said, data triangulation of different sources and synergizing data platforms. And I think that is something that we want to be able to do with new partners in technologies like Genesis. One other example of very exciting innovation that we have worked on is the Zipline project in Rwanda. And I'm sure many of you are familiar with that we really, Gavi played a very pivotal role in bringing together UPS Foundation, and we have Kevin, representing UPS Foundation, and they actually supported Zipline setting up this facility in Rwanda and really getting this whole drone delivery project off the ground. And now we see drones actually making deliveries of blood products and components to geographies, health facilities in geographies, which are normally very hard to access. So I think beyond Rwanda, this technology has huge promise for a lot of other countries in Gavi portfolio, which are very large, which have problems of tough geographical terrain. You don't have motorheads, you don't have roads, and you know, how do you take your essential medical supplies, including vaccines, and you know, mothers die because of postpartum hemorrhage because blood is not available. So I think you are saving lives through these new technologies and creating incredible impact. Another example I would cite of new work is around supply chains. And we know that it is not just important to develop vaccines and new presentations and products, but it is important to take them effectively and efficiently to children. And if you have malfunctioning health supply chains, you actually are not addressing the huge waste sometimes that you see in the system, inefficiencies and also delays. So what we are doing with some of the partners, and IFPW is here, and George is representing the International Federation of Pharmaceutical Wholesalers, we are trying to make sure that we leverage some of these new digital technologies in order to manage our supply chains much better. I'm from India, and in India what we did was that and actually Gavi supported that endeavor, we brought on board Logistimo. And Logistimo actually gives you real-time information and data on the functioning of supply chains. And managers can do a lot with that data in order to make sure that there are no stockouts and children vaccines actually reach immunization sites in time. And this has unlocked a virtuous cycle of inefficiencies. We also brought on board NextLeaf Analytics, which actually does remote temperature monitoring. And just to give you a glimpse of sometimes big issues with simple solutions, for example, when we started temperature monitors in India, we found that 40% of our vaccines were actually going into freezing. And if a vaccine goes into freezing, then it loses its potency. So you could actually be vaccinating children, but you are not necessarily immunizing them. So these are some of the innovations. One important aspect of our future work is going to focus on creating digital identity, because we know that all across countries that we work with, we have an issue of denominator. Civil registration of births typically is very weak in countries, and we really want to now explore the possibilities that are opened up to these new technologies to make sure that we give unique identity to children, track them very systematically, and make sure that they don't drop off the radar of immunization.
Thank you so much. It's interesting to hear how Gavi is not only focusing on the fact of research development, but it follows the vaccines through the supply chain in ensuring access and effectiveness. I would like to hear from Mr. Hiroshi on JICA's role and where do you position JICA in this conversation?
Thank you, Mr. Chair. I would like to address the question given by the organizer, how to increase investment towards the development of and universal access to essential health technologies. Investment is the key. And as my previous speaker said, Gavi is an excellent example which provided an ecosystem for innovation and investment. But I think there are other types of ecosystems needed to be put in place. And that is to say, the previous speakers have talked about the excellent examples of, state-of-the-art technologies being applied to various social problems. But my contention is that not only those established, accomplished professional organizations, but also dormant and potential actors be invited to the community so that the health conditions of the world is improved. So by ecosystem, I mean an environment where various stakeholders get together, share knowledge, share experiences, and forge partnerships, and where existing and strong partners get more opportunities, but also a new and growing stakeholders can get empowered. This kind of ecosystem is needed, I argue, because entrepreneurs don't grow automatically, and partnerships are not forged spontaneously. And private partnership, PPP, are not forged in a natural manner. So there has to be some ecosystems so that various stakeholders, both existing and potential stakeholders, can get together. And I would like to argue that there are ecosystems at 3 different levels are needed. One is an ecosystem at the local level. That means local potential stakeholders can be invited, can be tapped into so that they can participate in the productive endeavor toward universal health coverage. And I have the pleasure of referring to one of the projects that we at JICA are implementing in collaboration with the government of Rwanda and the private sector of Rwanda. That is the project of ICT innovation ecosystem strengthening. And the project has 4 pillars, among which one of them is to provide incubation opportunities for potential entrepreneurs in Rwanda. You know, there are abundant young people and abundant small and medium-sized enterprises in Rwanda who are aspiring to contribute to the health of Rwanda, and that technology is there, but not many investable projects available. Actually, money is already there, and what is lacking is investable, bankable projects. And you know, so what is important is to allow those small and medium-sized enterprises as well as aspiring youth to have an opportunity to come up with an idea that is investable and bankable from the viewpoint of potential investors. And we're now in the process of identifying several project proposals so that the originators of these ideas will be able to come up with bankable, investable project proposals. And I hope that our project will be able to present those outcomes in next year's Smart Africa or Transform Africa Summit. This is a local system, ecosystem that I argue is needed. And the second one is international level ecosystem. And this might be particular to Japan, Asian country, which is rather far away from Africa, but I hope this still applies to other countries as well. We have a large number of small and medium-sized enterprises in Japan, which are potentially interested in contributing to Africa's health problems. But they lack information, and they are not, they're psychologically very, Africa is very psychologically far from Japan. So they need some kind of public intervention so that they'll have an opportunity to get to see the reality of Africa, get to know the problems of Africa, and realize their potential contribution that they can make to African health problems. So the government of Japan, Foreign Affairs Ministry, and the Ministry of Internal Affairs and Communications and JICA have been teaming up to forge a kind of consortium of interested parties and to come to Africa and to get to know many potential partners. And you might have noticed that in this Transform Africa Summit, we have a rather large presence, including both private and public entities. I think this kind of intervention is pretty important and meaningful so that the potential actors which are looking forward to contributing to Japan but not currently unable to do so are encouraged to come to Africa and to get to know the potential partners. So this kind of national partnership forging ecosystem might also be important. And thirdly, and by extension of this second argument, I find that this Transform Africa Summit is a fantastic forum of global ecosystem of innovation and investment. I hope that in the future Transform Africa Summit conferences will invite even larger number of potential stakeholders from across the globe, Japan, US, UK, European countries, China, Korea, and many others, to showcase their potential contributions and forge partnership among them. Thank you.
Thank you so much. I really think that when we talk about the ecosystem and investment, it's probably need its session on its own, because it's such a huge and important topic that we usually need to talk about when we are talking about these technologies. I want this to be an interactive conversation, but before I open it up to the audience to ask questions and probably make some comments, I would like to come back to the Deputy CEO of Gavi, and maybe anyone who on the panel has a comment on that, on what do you think are enablers? What do you think make this work, and what attracts innovators and innovations to come and work, and how best do we create an enabling environment to make this to work?
So thank you, Israel. And I would say a few P's. And these P's are people. You know, I think it is important, like Dr. Vijay said, there are universities and academic institutions that actually produce those high potential individuals and people who really then develop into innovators. And then, of course, among people you have country level leaders, because country level leadership is so important. It is also investors, right? Because in the array of partners that you would typically look at, you would like to bring the country governments and the innovators, investors, the industry leaders, and technical experts together. So I really think people are at the heart of the enablers that we should look at very seriously. The second, to me, really is the purpose, because I think innovation must begin only when we are very clear about the purpose. A lot of times we want to pilot something without being clear on what the problem is and what the solution, what is the solution that we are looking for, and how technology is really going to help us get that solution. So I think purpose is extremely important, and in a lot of cases we find that does not necessarily happen. The third thing is the processes, and I think that's very complicated. Processes of any kind. First of all, how do you set up a process to actually identify a good technology that's going to be meaningful or purposeful? How do you test it? You know, how do you create that environment where you can actually test innovation? Because as has been said, innovation also has a high chance of mistakes and failure. So I really think it is important that we create that environment where we have high tolerance for some of our experiments to fail, and then we take a step back and say, okay, what is it that we have learned from that? Processes would also, to my mind, include regulation. You know, what is the kind of regulatory framework that country is putting in place? And we were discussing that in our pre-session conversations. You also cannot take regulation to a level where you stifle or kill innovation. So I think processes are important. The last two things, one is platforms. We have already discussed that. How do you build those robust platforms which are shared, you know, and which are synergized, and which really then allow for seamless work to happen, and partnerships, as I said, are critically important. People have to work together with each other, and otherwise the space is going to become extremely fractured, and rather than driving impact, we would end up confusing country governments which are already grappling with the constraint of resources.
Prof. Kumar?
Yeah, so I just want to add a couple of things to what Anuradha very eloquently described. First is that connectivity. We are talking about the use of digital technologies. So whether it is signals or images or videos or just plain data through Excel tables or something like that. If it sits in local places, it's not going to be giving you as global information or as regional information. There has to be ways of collating, bringing all the data together to extract the nuggets of information from that. This requires connectivity. Okay? So this is the theme of this summit, and this issue about, why isn't every place connected well? This has been brought up multiple times. And of course, health is one of the big drivers for connectivity. The second is you can have connectivity, but you also need power, like I said before. There are many parts of Africa still that don't have a power grid. So you have to come up with microgrid type of solutions. There's a lot of research that still needs to be done. We at Carnegie Mellon have people working in these areas. They're going to local places and finding this information. Of course, as mentioned before, regulatory environment, I think, is a big thing. I don't have to say it over and over again. And finally, I'll come back to the fact that you need talent. Talent that is sensitive to local issues, that knows, that has grown up here and knows the problems. I just came to know this morning when we were all talking that in some parts of Africa, apparently women don't go to see the doctor unless the man in the house permits it. Okay, if you collect data, that is not going to be very useful because the data is flawed. It's not representing the reality. So one has to be aware of all these kinds of issues, and it's best done by people that have lived this life. So that's why at Carnegie Mellon, we are training African students for Africa. Of course, one of the enablers for us to be able to do it is the financial support for these students to be able to attend places like that. So we are very thankful for the support from the government of Rwanda and Smart Africa through scholarships for these students. I think we are looking forward to continuing that work to produce even more talent that will solve these problems.
Thank you. Maybe before I get to others, I would want to hear about what do you do in Ondo States and how do you attract and keep all the multiple initiatives that you mentioned earlier in a minute or so.
First of all, talking about enabler is two-way thing. The solution, the intervention must produce results for you to buy into it. In 2015, we had a terrible epidemics. People started dying. We were not sure of what was the cause of the death. The ministry was confused. And okay, the Istra Global came to us and said, okay, let's use this technology to help you in this outbreak investigation. Line listing was done. We put into that tablet. We all went to the community. We started interviewing people using those tablets. Before the end of the day, we analyzed the results and found out that people were taking methanol as alcohol, contaminated alcohol with methanol. It was that day, it was the analysis from the Istra Global technology. Using that tablet, we were able to get that result. Of course, the ministry became so interested in Istra Global. And this woman resources issue, challenges of how to train people, they come hand in. So the ministry became interested, and the governor said, okay, this organization, we must work with them. So we now started providing the environment for them, providing accommodation for them, working hand in hand with them, also buying into those solutions. So it is results that is actually the enabler. If you come with solutions, a lot of people came with different solutions, but of course, time they've withered away. But we are still with them. The IPP project, like I said before, the video training is another innovation that the state is working on. It's expanded beyond the secondary level, getting experts to come and provide training, video training, will take it to various facilities. So it's the result that is the catalyst for us to provide the enabling environment. So we are also investing resources on it to ensure that the achievement does not go down. I think that is my contribution. Thank you.
That puts some pressure on the first actors. Usually they have to provide results so that the states or governments get to open up to more innovations. JICA, and then we will hear from the two companies who actually work on the ground.
Yeah, I'd like to add several footnotes to what my previous speakers have said. And one is the importance of having the clear objective first, and not dominated by the intention to use a certain technology. And the importance of socially sensitive, being sensitive to social contexts. And as I said in my initial intervention, I believe that local, international, and global ecosystems are necessary. But especially when it comes to local ecosystem, is a very important forum or a space where various actors can come together and to really come up with socially workable project ideas. And we have often noticed that entrepreneurs in Rwanda and in other countries as well come up with an idea of a project, but driven by how to use this particular idea. So if you have a hammer, everything starts looking like a nail. So you have to be very careful in identifying the real need of the society and how to match your technology with the social needs. And for that kind of purposes, local, national, and the global ecosystems are important. I'd like to reiterate that point. Thank you.
Thank you. Just to expound on that, when you're innovating, you need to start from a need. And as you were saying that, you need to start from a need. What do people need? And when you're finding a solution, find a solution that is easy and convenient and very easy to use. So if you develop a platform, it might be as complex as you want it in the back end, but at the front end, make the person be able to use it in a very easy way. Otherwise, if you're going to develop a platform and then you need 3 months of training for the user to use it, then it doesn't matter how important and how useful it is, it needs to be able to be usable. I think that's what I wanted to add. Usability. Make it simple and easy for everybody to use it. Not everybody's an IT person. So have the end user at the back of your mind when you're making developments. Thank you.
To echo the theme of purpose-driven development, I think earlier when I was talking about this idea of fragmented data systems, where you've got health management systems data over here, supply chain data over here, surveys done by a research agency over here, often that's a symptom of the human silos that exist between these different departments. It's not just a technical challenge. And I think often when ministries of health think about how can we implement a new technology to solve our problems, they look to the IT department and say, okay, go and find this technology, implement it. And sometimes what we see is that there's not enough consultation with the actual implementers or the actual people who are involved in designing policies, determining where resources need to go. And so we started this almost from the back, and instead of starting with the question of what technology should we be implementing, we should be asking the question, why are we implementing why do we need to implement a given technology to solve a given problem? And so when we do a project, for example, and we'll come in and work with the Ministry of Health, we'll talk to the different case teams or directorates inside of the ministry and ask them, what are the key things that you're trying to do that you can't do right now that you suspect you might be able to do if you had access to other directorates' data? And so something we might hear is an immunization team might say, well, we have a lot of stockouts that happen all the time, and it's because we can't see supply chain data. And so that informs, okay, well, maybe we need to start with an integration that involves routine health information, survey data, and supply chain data, and then iterate from there. And then we'll go to the TB program and learn about their needs, and then learn about their data systems and integrate from there. So by beginning with the question why, we then determine what the technological solutions are, not the other way around, not starting with the technological solution and then try to find a way to solve all problems. it has to be a very collaborative process, and to the point about what are the enablers that make it successful, you need to have top-level interest in this. Often there are going to be, when you're implementing a new technological solution, embedded interests that are opposed to it for whatever reason, whether it's not wanting to give access to data or not wanting to cede responsibility to another directorate. You need that top-level leadership to break down those barriers. And I think if you're interested in working with the private sector, a certain appreciation for our model is a little bit different in terms of wanting to act quickly in order to, and as part of that, I think there's a learning curve for both sides. Private sector companies that want to work with governments need to understand the realities on the ground here and need to accommodate those in a way that maybe private sector companies are not accustomed to doing. But at the same time, there's a certain appreciation for the needs that private sector companies have in order to program resources more quickly or be able to operationalize more quickly than traditional partners of the past have. So I think with those, when you get the people, when you get the priorities and the purpose, to echo your point, I think that those are the factors that you need for success.
Thank you so much. I had more points, like how do we measure success, or what does success look like? I also wanted us to discuss on data. How do we work in Lego frameworks that are non-existent or really not addressing the innovation that we are creating? Or how do we work in unknown risk, like culture or traditions? How do you address those? But this is just give clues to people who want to ask questions. Those are 3 topics that I still remain with. So I will take questions, and you have clues of questions to ask about. So, who has questions, and can we make it straightforward and quick? Microphones, please. So I will take the first one here, the second there, and the third there, and then fourth, and then we will get the panel to answer those quickly. So your name, organization, and it's one question so that we get to take many more. Here, please, in front row.
Thank you. My name is Maximilien Podjedo, and I'm the CEO of ASSI. ASSI, the National Information Systems Agency for Republic of Benin. And I'm also the Digital Transformation Director for Benin. I have a question from what I have heard this morning. I heard a lot of success stories. What do we need, for example, to achieve our goals? My question will be a little bit opposite. Throughout your experience, what was key failures you encountered while you were addressing, bringing technology, for example, for development, so we can learn from it? Because there's a popular saying who said that your best teachers are failures. So this is my question.
Thank you. Right behind you.
Thank you very much. My name is Tomo Naito from JICA, Japan. Actually, one question to the other, maybe some of the panelists. I leave it to you, the moderator, to pick up who will be the answer to my question. As far as I understand, the digital health itself have actually the front side and back side of coin, actually 2 faces of coin. Actually, digital health is not only for the people who have smartphone, people who have connectivity, people who have a sort of the affordability. So actually, if you look at the SDGs, for example, actually health is really one of the most important things, as we all know. But still, as we also all know that 800 million people are suffering from stunting, a lack of actually a lot of things, nutrition. So in order to overcome, or in order to tackle with those kind of existing conditions by using the power of ICT or power of the digital, my question goes to actually to some panelists that how we can overcome or how we can address to that kind of the very, very fundamental actually challenges, which the most of the potential beneficiaries are living in outside city, who doesn't have smartphone, who doesn't have connectivity, who are not actually have enough or sufficient money to pay for all those kind of things. Thank you very much.
Thank you so much. An interesting question. We have one question here. Yes.
My name is Daryl Collins. I'm doing a PhD in supply chain management. My question is, there's a lot of data which is being collected, and what are the systems which need to be put in place to ensure the security of that data so that the individual is protected? Thank you.
Thank you so much. And one question from the WHO. It's right here.
Thank you very much. My name is Derek Munene from WHO, Regional Coordinator for Digital Health, and thank you to the panel for a very clear and very articulate discussion covering multiple topics, very stimulating ideas. My question is to Shivon. I'm not sure if I pronounced your name correctly. I was very impressed by your implementation, on artificial intelligence, because it's, I think, opens remarkable opportunities for universal health coverage and etc. Like you rightly talked about. I would like you to comment a little bit on the legal framework in terms of how do you manage this change from physicians who have had medical training and are equipped and trained to make diagnosis or medical decisions? How do we transition that to the platform where machines are beginning to guide the process? As you rightly mentioned, some machines are able to provide the diagnosis. Now the legal implication of that, could you comment around your thoughts on how we can support member states to ensure that they have an appropriate legal framework to ensure that the patient safety is guaranteed, and the fact that you don't have any adverse results as a result of having a machine guiding the process without a human intervention. Just a reflection, and again from WHO, we're interested in making sure that member states have enough guidance on how to harness technology in full view of regulations. Thank you.
Thank you so much. Who wants to go first? Yeah. We can start from this side until the end.
I think I'll address two of the questions. Somebody who was asking a question about how do you address the question of using basic technology to the people that don't have smartphones. And I'll give you, exactly what it is that we're doing. In London, when our company is operation in London and is also operation here in Rwanda, and in London, everybody has an app where you can just do your own triage. And as I said, that you'll eventually be able to do, diagnostics and so on. When we came to Rwanda, we realized that only 10% of the population have smartphones. And so we had to quickly adapt and say what works in Rwanda. How do we address, how do we provide the same care to somebody who lives in a village somewhere? So our platform is such that all you need is mobile network. If you have, 3G, 2G mobile network, and you can access, and you have a phone. And in Africa, majority of people have phones. They might not be smartphones; they are feature phones. But people, an old woman in a village somewhere, everybody uses a phone somehow to do their mobile banking, to do all sorts of things. And that is why we're leveraging on the existing technology that you have in your pocket, that you're using for your banking, that you're using for your phone calls, that you're using for everything that you're doing anyway, to allow you to have access to healthcare. So we have a very easy platform. And also, I think that's why I was talking about make it usable and very easy and convenient for somebody to use in a language that they understand. So we developed a USSD platform here in Rwanda where, you just, for example, just dial 811# and you put in your NID number and you're registered. You just do the same thing and ask for an appointment and go about your business. Somebody is going to call you. You're going to receive an SMS to say, go to a quiet place. In 5 minutes, somebody's going to call you, and that is how you'll get your access to healthcare. So it doesn't matter that you don't have roads. It doesn't matter, as long as you have a mobile phone, which most people in Africa do have, then you'll have access to healthcare. that is addressing that question. I think the specific question that was addressed to me was around the issue of regulation. What happens and I'll give you a specific example also here in Rwanda, not about AI, but when we started operation in Rwanda, when we started operation in 2016, we did not have sufficient regulatory framework around what we do, and what happens in leapfrogging companies. Sometimes the operating environment does not provide the relevant regulation to support you. So sometimes you have to work with the government. We did that with the Ministry of ICT to develop regulation around privacy of information. As a result, if we need to, everything is stored in Rwanda, we can't, even basic things like the code I was telling you about, we can't store it on the cloud because now there's regulation that governs us. The AI we're currently developing in the UK, there is EU regulation that we have looked at that governs artificial intelligence and all that. And it's about sharing, actually. I was talking to my director of IT, and we've shared the EU regulation to the Ministry of ICT to say, this is what's governing us in Europe. This is potentially what you could, So I know that currently there's a draft regulation around this, and there's synergies. And usually, that's how, I'm a lawyer, I have a law degree, that's my background. And sometimes you have to develop laws, you have to see what people are doing elsewhere. You don't have to, reinvent the wheel. It's to see what regulation is happening elsewhere. So it's to support, to say this is, because the AI technology is already in use. People and they use it on their mobile phone. Then you are not a medical person, but you can triage yourself. There's regulation around that. So that regulation is then, how can we use similar regulation around that? So we are in close collaboration with the Ministry of ICT to be able to do that. Thanks.
I think I'll take the question about failures and then also a question about data security. I think that a lot of the comments that I've shared today are informed by lessons that we've learned along the way. And so this idea of starting with the problem first rather than the solution, which is the technological solution, but actually understanding what the use case is and then figuring out how do we then implement our technological solution to solve it, I think is one of the key ones. When we do a project, we will embed ourselves first with, let's say, the Maternal and Child Health Directorate and solve their problems by using a technological solution, as opposed to being embedded with an IT directorate, for example. So we'll work closely with both. But when we take an IT approach to solving a policy priority, sometimes I think you can stumble. And so it's really important to have the why question up front and center. Why are we doing this? Is it to prevent stockouts? Is it to prevent service gaps in service delivery? Is it to prevent the next infectious disease outbreak? And then that informs the work, not the other way around. I think one of the other things that I wanted to add was, as important as it is that to get that high-level political leadership, it's imperative that you also have organic interest and empowerment as well. And so even before we'll start a project, we will go to, let's say it's with a Ministry of Health, and talk to every single directorate and every single case team inside of that ministry to understand what are their biggest policy priorities, where do they perceive the biggest deficiencies in service delivery to be. And then only after we've had this very bottom-up investigation and scoping mission do we then present our findings to a Minister of Health or a permanent secretary and say, these are the demands that we've heard from your ministry, and this is the way that we think that we can implement our data interoperability platform to solve them. So it's important to have both sides. From the political leadership, you need that to break down barriers when offices can't or won't share data for whatever reason. But you also need that organic interest from the actual users who will then use the platform to solve the issues that they want to solve. And to that point, nothing breeds success like success. If you can work with a Maternal and Child Health Directorate, for example, and help them optimize their supply chain so they've saved $30 million, all of a sudden every other case team wants to work with you to figure out how they can do the same thing. And by the way, so does the minister, and he or she wants you to work with everybody in the ministry too. And then the last part is, I think that in the past, whenever we have developed a feature without it being a user-driven feature request, it's fell short. And so we have a highly modular and scalable platform that's meant to go into a variety of contexts and rapidly integrate data systems. But I would say almost every feature that's been developed was developed as a result of what our end users told us they needed. And when they detected that there were deficiencies with the way the platform worked, we fixed it. When we did it the other way around and we imagined what the problem was and we built a tool or implemented some kind of artificial intelligence forecasting tool without consultation, you don't have usage. So it's really important to have that the user-driven design style in terms of implementing a new technological solution. And then to the data security side, I think if you're dealing with personal data, end-to-end encryption is imperative. And at least for us, we use bank-level end-to-end encryption to ensure individual-level data. But actually, the majority of the data that we end up using is not, it's typically less sensitive than that because it typically is aggregate-level information. Most of the analyses that ministries are doing, with the exception of specific case management examples, are typically looking at what is the aggregate level of commodities used in this particular pharmacy or this particular warehouse or distribution relative to consumption in this health management information center, health management information system relative to what is our survey data telling us about where there are coverage gaps, for example. So at that level, you have a certain level of anonymization, and so the level of privacy that you might be infringing on is reduced greatly. That said, when we do have cases where we're dealing with individual level data, there's a variety of things that you can do. In addition to just the encryption and data security piece, we can anonymize the data sources. So instead of looking at somebody's individual name, you're looking at a randomized number to represent one person. That you can then set governance controls to say only the person that manages this, that is authorized to manage this person's data, can access the actual underlying information. Anybody else at an analytical level can only access the anonymized number, for example. But then you can also set additional governance rules as well. Only people within this particular program of this particular ministry can access these types of data or at this level of aggregation, et cetera. So I think when you think about data security, it's really important to understand why do you need that data security, and that then informs the types of rules that you need to build in order to guarantee it. So there's a certain amount of technological things that you can do as far as encryption, anonymization, et cetera, but there's a lot of processes that you need to think about as well in terms of why do people need to have the access to what, to then inform the other rules about how you govern access to sensitive information.
Maybe, Deputy CEO, in addition to the question that you will address, can you also talk a bit about how we measure success, especially on the question on accessing and make sure this technology work for the very fundamental issues? I don't know if it's relevant for what Gavi does, but I think it's important to address.
So let me just try. I wouldn't echo what Walter said on lessons learned from failures. I completely agree with him. And just a couple of things on definition of success. And this is also linked to the lessons that we learned as we experimented with our innovation agenda. First is that you have to do things at scale. You know, if you're piloting too many innovations, countries, communities lose interest, the transaction costs are very high. So I think really trying to get to scale rapidly is extremely important from success perspective. The second is affordability issue. You know, in the long run, I think we have to very carefully assess the costs of innovation, and because if there aren't any cost reductions, or it isn't cost effective, or benefits don't outweigh costs, then there's going to be a huge question mark. The third is sustainability, and that in part is linked with the affordability issue, but also part in where the financing is coming from. So as you look at Africa and a lot of countries in the continent, you would find that a lot of this innovation is actually fueled by external funding. So I think, and Gavi has this model where right from the beginning, we actually promote this notion of country ownership and financial sustainability. So when we start to provide vaccines to countries, there is a very small component of co-financing that countries have to put on the table. It is just 20 cents per vaccine. However, we start to ramp it up as gross national incomes go up in countries. So this is a very, very powerful model, and we have seen countries actually putting on table domestic resources, taking much greater ownership of their vaccination program, because when Gavi started to work that time, countries were not even paying for the traditional vaccines. And now they're paying for traditional vaccines, but they're also picking up the tab for more expensive new vaccines. So I think this sustainability is something that we absolutely have to look at very carefully and factor into the design ab initio. And the last thing that I would mention is really impact. What is the, so if you're looking at scale, but then you could be implementing something at scale and yet impact could be very small. So I really think bringing that impact lens, and Gavi does that all the time. So I rattled some numbers, right? So we actually look at impact right from the beginning, our inputs, what are they going to produce in terms of impact, and we measure it. And then we showcase it. And that is why donor confidence in Gavi's success is so high. Now coming to the question that was asked, we have so many million children suffering from stunting, innovation, use of technology. Just a couple of things. One is, success is not necessarily about doing different things. To my mind, it is about doing things differently. And that's where innovation happens. And you really, if you're looking for success, you have a choice to make, right? You can actually follow a sluggish rate of change, or you can actually decide to accelerate or leapfrog. So I think that's where a choice rests, and then what is doable and what is feasible. Because innovation, to me, is a combination of three things. One is old problem. The problem is old. It is not new. Technology is new. So it's a new technology, and of course the power of big ideas. So when you bring all these three together, that is when you really have purposeful, meaningful innovation.
Anyone on that side who has an answer? Yeah. Prof. Kumar, then on the stage.
Yeah, I just want to touch upon a few of the questions asked. The question about what do you do when people don't have smartphones or connectivity? I think connectivity is important. Without connectivity, there's not a whole lot you can do. I think so it needs you need to have connectivity, but you don't necessarily need smartphones. I think feature phones, if taken advantage of in creative ways. I'll just give you one example of a project that is being pursued by faculty members in our campus. So after giving delivery to a child, there are some women suffer from postpartum depression, and it needs to be diagnosed. But there aren't experts in the local areas to do these kinds of things. So one of the projects is pursuing if we can analyze people's voice as they use their regular phones, feature phones. Okay, they don't have cameras or anything like, just voice signals. And can we have an early intervention in case of some signals? So this is using basic phones, but then using speech technology and machine learning ideas to see if this is a hypothesis at this stage. We have to see how well this is going to work. So that's just one example. But I think the thing to think about is just to start from, as some previous speakers said, understand the limitations of the context when you come up with solutions, not the other way. Okay. I also want to take on the question about security of data and privacy. I mean, I work in data science and signal processing, so we're all enamored with the data. And now, as somebody said, we are drowning in data, actually. There is so much data being produced. But when we're talking about health data, now this ratchets up the privacy and security issues one more level. Okay? At least in the US that I'm familiar with, there are rules about sharing data, and I hear that European Union also has a very strong privacy requirement. And those have to be taken into consideration right from the beginning, not as an afterthought. Okay? Same thing with security. I mean, everything looks good until some hacker is able to get into some maybe minister's personal computer. Okay, this can happen, and this happens all the time. And they get into computers in banks, which have significant encryptions and all that. So we got to think about cybersecurity as we develop these solutions. Now, this means that there has to be a legal framework that requires people who are developing solutions to be accountable for the security of that data. Now, this is a double-edged sword. While you can ensure privacy and security of the data, you also might be stifling innovation. So this is where I think the governments and private enterprises and even universities have to get together and figure out for a particular environment what is the right mix of these parameters. There is no single answer that will work in every case, but this requires dialogue. Most often what happens is a technological solution is first provided, and then later comes the discussion about privacy and security. But my thinking is it has to start right at the beginning. That has to be one of the things. So lastly, somebody asked a question about, does machine learning basically replace doctors? Okay, I don't think we're there yet. I think, but machine learning can help reduce the burden for doctors. That's the way to think about it. I mean, I myself had a research project where people were wearing these wearable ECG, heart signal, cardiac signals. And these are patients that have gone through some procedures and they have to be monitored. They wear this device at home. The cardiologist is not there constantly monitoring the signals, but the signals are being collected. If there is a machine learning program that's, is analyzing this at least at a lower level, and sends a signal to the doctor or nurse or whoever saying, oops, you need to take a look at this part. That's where I think you make the best use of doctors' nurses' time. So as long as it isn't, we don't have to think of it as either this or that. I think there is a long ways to go before we won't need any doctors. Okay. Thank you.
Thank you. Yes, please.
I'll be brief. The response to the question on challenges, yes, we had a lot of challenges initially, and that is the health workers did not initially believe that you can manage data without using paper-based methods. It took quite some time before they key into it. Secondly, the issue of 3G network failure in many of the remote areas. But of recent, the international partnership projects funded by Inmarsat and the UK Space Agency have been able to deploy satellite technology, providing a network using satellite technology for those hard-to-reach areas where there are no 3G network. But the challenge still there, that all the facilities that do not have the 3G are not yet covered. So we are working on seeing how that project is expanded to cover all the areas that do not have 3G. Thank you.
I had forgotten about the question. Apologies. There was a question about, does AI replace doctors? So 2/3 of what is now known in medicine has been discovered in the last 5 years. So if you're a doctor that has, was in medical school 10 years ago, you need artificial intelligence to know what's going on currently. In fact, in the very near future, it will be almost unacceptable, even careless, for a doctor not to use some form of AI to inform their decision-making process in using artificial intelligence. So I think it's going to create linkages, enhance the way people access medical care. The artificial intelligence mechanism that we're building is the world. Anyway, artificial intelligence, it has about 5 billion strings of knowledge. The more you input, the more it learns. If we bring it here into Rwanda, for testing purposes, then it will be an expert in tropical diseases. And so this one center of knowledge on anything else will be an expert on all things medical. So it will be an enabler for an existing doctor to use some form of artificial intelligence to better their expertise. So it's more of a collaborative rather than something that will take over. Thank you.
Thank you. I'd like to make a short response to the question of failures, although this might be in a somewhat different context than the one you raised. As I said, JICA has been introducing a facility or facilities through which we encourage the private sector, small and medium-sized enterprises in Japan, to be more interested in the developing world, especially in Africa. And we have chosen a bunch of projects, and they have come to Africa and surveyed the market, and then finally come up to the decision that this is not feasible. And some amount of money has been used, well, not in a very productive way. We don't call it a failure, because official development agencies don't use the word failure, but we call it rather unsuccessful cases. And so this leads to the argument that the ecosystem, I've been telling this all over and over again, it is required. Because in order for the private companies to be well informed before they make a decision to come to Africa or to Asia, they need to have a sufficient amount of information and the kind of pre-knowledge before make a decision. So I'd like to once again reiterate the importance of local, national, and global ecosystems. And one thing, and how to deal with the people who are hardest to reach. And we must be reminded that be reminded that the ultimate goal of the Sustainable Development Goals is to leave no one behind. And I think this is a very important issue. And of course, we can hope for the advancement of technology in the future, and we can rely on the very innovative approaches adopted by social entrepreneurs, local social entrepreneurs. But basically, I think to care of the people who are hardest to reach lies within the responsibility of the government. And maybe the international community has to support the individual governments to come up with whatever ideas they have to support the hardest people who are in need of help. Thank you.
Thank you so much. It looks like we've run out of time, but I will take two very urgent questions. Someone who feel like they won't leave this room without asking this question, and then it's 5 minutes. I'll take the lady in the back and the lady in the front. Sorry, don't hold it personal against me. Here. Please, can you raise your hand for the microphone? See.
Good morning. My name is Dr. Omas. I'm a digital health provider. I want to thank the panel for a really insightful discussion. It's been very thorough. My question is, as regards access to and outcome of healthcare services with leveraging telecom, what we have noticed from our own efforts is that those people who are originally underserved in terms of access to healthcare, even with your interventions, they tend to be underserved to your efforts of intervention. So I'll give you an example. They do not have the traditional access to healthcare because there are no roads and there are no healthcare centers. And you're saying they have a phone. So we say, okay, we want to avail these people basic healthcare information because when they know better, they could do better. And then you find out that they do not even have strong network services. So it's like they're doubly underserved. And then the further you go, the further, they are underserved. How do you really help?
Okay.
Thank
and
you.
then one question here in front, and apologies for everyone else, we are running out of time. Here in front.
I did have a question for Genesis and for the ones who are collecting actually data, because I'm coming from the European Union side. We do have a way to have access to de-identified and anonymized data via Custodix. So there is a company called Custodix where you can actually reach out to any hospital which is having an EMR system and say, this is what I'm looking at, can I have access to the data from the hospital? And they sort of are the ones who do the middle management. You have EMIF in the US as well. So I'm wondering, looking at Transform Africa, where we're thinking of an African Union, how are we going to manage and access de-identified anonymized data in a way that benefits the African population everywhere? And Genesis, with regards to how you guys are working, are your servers locally placed? And with regards to all the IT laws and policies which are changing and where you cannot take data out of the country, how are you guys operating?
So maybe to put in context her question, it was about you don't have access, then you provide the solution, and the solution doesn't really give access as it was needed. So it's sort of, maybe here, we are in the heart of Zipline. People always ask us, you don't have roads, then you use drones. Does that mean you will never build roads? And so maybe, do you want to address that, Deputy CEO?
I would look at this situation slightly differently. First of all, I couldn't agree more that now the focus of all our attention and efforts and investments really have to be the excluded populations, because that has to be our definition of success. To what extent are we reaching unserved, underserved? And that is where Gavi is focused now. The second is, I also think that we have to think about innovations more broadly, as I said in the beginning. And innovation is not confined to digital technologies. Digital technology plays a very important part in innovation ecosystem, but that's not all. So for example, visualize a remote, hard-to-reach area or population. So what, for example, Gavi is doing is that we are market shaping on cold chain, right? Because traditionally, cold chain equipment has been very dependent on power and electricity, right? But now with our intervention, we are getting the next generation cold chain equipments, which are solar powered. So, so this kind of innovation enables us to find a solution for those hard-to-reach remote areas. And the moment we take our cold chain to those populations, you can be quite assured that with other building blocks of health systems, the services would start to reach those children. Another example that I would say give is, for example, of providing some special incentives to the community health workers who are rooted in communities. So how do you identify those women or volunteers from within the community and put in place innovative mechanisms to train them, develop them, give them supportive supervision so that they're anchored within the communities, and how do you? So just wanted to say that yes, digital technologies of course are important, and with all this there is still space, like as I said, you can on supply if you need to, so you can provide cold chain in that remote facility which is solar driven, but then through drones you can actually provide the vaccine, because you don't have. So it's really a mix of strategies that you would adopt in order to really get to that last child or person.
Maybe from Walter, and then we will finish on that side.
Sure. So to answer I heard two questions there. To answer the first question, I think it's probably more complex than we can get it, that I could answer all in up here on stage. I think one of the challenges to understanding how could you have some massive EMR system or exchange of data across multiple EMR systems, I think there are so many different sub-elements within that that lend itself to the complexity of the challenge. One of the challenges that comes to mind that we've faced in other geographies is, we have, in one particular country, we integrated a number of different systems, all of which were tracking patient-level data. And what might happen with let's say, an HIV-positive patient is that you might go to one facility to find out, to get tested for HIV, go to a second facility to find out the results, go to a third facility for referral for treatment, and then go to a fourth facility to actually initiate that treatment. Every single time that patient will sign in and maybe say, in this place my name is first name, last name, here's my date of birth, and that second place say first name, last name, here's just the month of my date of birth. And that third place spell the first name differently and not include the last name and maybe provide a date of birth, any variety of that. And so we'll do things to figure out that is one person accessing 4 services, not 4 individuals accessing a single service. So that's just one challenge that's involved with trying to integrate different systems. Then you also would get into, if you're trying to do it across borders, then you're getting into data privacy laws, which might differ from one country to another, for which then I would need to contact our lawyers about how we would address that. But that actually lends itself to the second question. In addition to all of the technical complexity of making systems interoperable, we have an approach that says that at the end of our implementation, we want 100% country ownership of this platform. And so as part of that, in order to do that, when we engage with a country, that means that our project managers and engineers are based in the country, working side by side with the Ministry of Health, with the Pharmaceutical Supply Chain Agency, with the Research Institute, whoever the data users are, to make sure that the implementation is done just right, so that it's usable, but also so that there's knowledge transfer, so that they not only know how to interact with this data, to use data for decision making, but so that there's an appreciation for how do you maintain it with or without us. So that when a brand new data system comes out 5 years from now, that they know how to do the integration themselves, and they don't have to call us. We're happy to help. We're never our goal is to increase usability, increase usage of these platforms, so we don't abandon countries, and we're with them as long as they want us to be there, and as long as we can support them. But our ultimate goal in the end is not to be here forever in a country. Our ultimate goal is for a platform and data interoperability solution to be that country's platform, and to help that ministry be able to administer every element of it, from the data analytics side to the IT administration side. And so the only way to do that is to have a totally user-driven approach that makes sure that on the implementation side you address every single one of their needs, and is ultimately done in a way that is reflective of local laws, local regulations, and local needs. And so as far as the legal framework is concerned, sometimes that means countries, according to their data access laws, that you have to have all data stored on servers in that country, and that's fine, we'll do that. Other countries are more flexible and say that we can have data in the cloud, and that's fine, we can do that too. We want people to use the platform because we believe so deeply in the power of triangulation to improve resource allocation and ultimately improve public health outcomes. And so we will do what needs to be done in those countries in order to have a successful implementation, and that includes complying with any and all relevant local regulations.
Mr. Francis, you had something, and then Prof. Kumar will have the last word.
Okay, I will respond to the first speaker. Issue of accessibility is actually not a problem in Ondo State. The national policy is that there should be one health facility per political ward. In Ondo State, we have 203 political wards, but we have 583 functional health centers, which means there's no ward that does not have about 3 health centers. Only few have less than 3. That means you don't have to travel up to 1 kilometer to be able to access health services. Our challenges now is how do you ensure that those health centers have qualitative health care services? What are we going to use to ensure those quality health care is delivered to those facilities, to the rural populace, to the hard to reach? And that is why we're embark on this innovative technology to improve healthcare services. So R is not issue of access, but issue of quality, improving the capacity of the health workers, ensuring that data is properly managed, ensure that epidemics response is done timely, ensure that even integrated supportive supervision is done by our agency using the information coming from the electronic data management system. If we receive the report, we'll know where our challenges. When we want to go for integrated supportive supervision, we'll first hold pre-supervision meeting, looking at information that is coming from those data. We'll now say, okay, there are challenges here. We'll have to go as an agency to go and address this issue. If we need to deploy more staff, if we need to provide more reagent and all, we'll do that. Thank you.
Thank you.
In the interest of time, I'll not repeat any what was said. The one thing I wanted to point out was in yesterday's one of the panels, someone pointed out that even in the United States, there are many rural areas where the connectivity is very, very poor. So there is actually a special program the government offers for folks in those areas where they get handsets, basically mobile device units, and even the connectivity at a highly subsidized price. And of course, who pays for this? It's the other customers in the form of taxes that are put on the service. So, I mean, there are models for how to make connectivity available to underserved areas. Whether it works here or not, that's a different question, but there are other models.
Thank you so much, and thank you so much to all our panelists, and thank you so much to all of you who made it here to attend. I would like to thank the WHO Afro and the ITU and the Novartis Foundation for co-sponsoring most of the events in the Digital Health Hub. We have only 15 minutes until the next one, and so you can just grab coffee and come back or stay in the room to ask more questions that you had. Thank you so much, and hope you enjoy the rest of your day.